We're going to now move into the question and answer session. So we're going to move into, we're going to welcome back some of our previous speakers. We're going to welcome back Betty, and I'm also going to introduce Danny Altman, Professor Danny Altman from Imperial College, Professor of Immunology, who's going to be joining us for all of the sessions today, all to take part in this question and answer session. So if we can ask all speakers to put their videos on, and we'll start with asking the first question. And I'm going to start with Betty, because this is a question we'll start thinking about mechanisms of why things are happening in long COVID. A number of questions in the chat about why patients get brain fog and what we can potentially do about brain fog. So Betty first, anything from the research on multi-system involvement that explains this phenomenon?
Thank you, James, and thank you for the questions. So the insights that we have from our multi-organ imaging study are quite interesting. So I did mention very briefly that we saw abnormalities on MRI, which were basically suggestive of potential inflammation-related changes. And the reason for that is we looked at the correlation between objective measures of tissue health on MRI and blood biomarkers of inflammation. So it is possible that there is a form of grumbling inflammation that is ongoing, that is contributing to the way people feel. As for the question on brain fog, well, so that's also an important question because this is a very common symptom. Currently, we have not seen an association between the MRI markers in our cohort, but there has been a paper that was put out by the UK Biobank, which is a nationwide follow-up sort of biobank that undertakes comprehensive assessments, blood tests, questionnaires, and imaging of people who are willing to participate. And the UK Biobank had MRI scans of people before they had COVID and after COVID, and a lot of other assessments. And they have seen changes on the brain to suggest that the gray matter volume in some parts of the brain reduces in size or shrinks. And actually, when you look at other disease models that have similar findings, so they're seeing similar changes in diseases like Alzheimer's and Parkinson's. So there is obviously there is a working hypothesis that whatever is occurring in patients who are suffering from long COVID, may predispose them for longer, more permanent damage. And we really need to understand why this is happening. And there's definitely some markers on imaging to suggest this is happening.
Okay, I think that's really useful. I think that'll be of great interest to many of the people asking the questions today about. So brain fog has come up again and again in the chat and the Q&A. So I'm going to bring in Danny on this as well. Based on what you've seen so far, are there any clues in these studies that Betty's talking about or other studies that would give us an indication of how we might be able to treat brain fog or the neurological effects?
Sure. All I'd add to everything that Betty said is that, we all agree that we're talking about a multi-system, multi-organ disease. And when immunologists talk about that kind of stuff, the brain is no different to any other part of your body. So, if we think that there are white blood cells that can release things that are pro-inflammatory and making you feel rubbish, things like tumor necrosis factor and things like that, if they can do it in your kidney and your lungs, they can certainly do it in your brain as well. So we don't need special explanations for brain fog. We can use the same ones, and we can probably use the same kind of drugs once we sort out which are the right ones to give.
Yeah, so staying with that, so from Martin's survey and also from Krishna's data, this seems to be a very diverse condition with lots and lots of different symptoms. Is that to be expected even if the mechanisms are quite similar, as you're suggesting, Danny, or does it suggest that there's different mechanisms at play in different people?
So I accept that long COVID is a work in progress, and there are kind of stratifiers and there are lumpers, and that's the nature of medicine and trying to write the textbook in real time. For my part, as I'll try and explain in my talk, the immune system is all over your body and doing things all over your body. So I feel like I don't need lots of different explanations. I can probably work with a small set of explanations, but I'm open.
Okay, so Krishna and Martin, one of the other questions that's come up a lot in the chat, I think patients are looking for a bit of hope. How often, based on the surveys and based on what you've seen from the reports, how often are patients getting better? And do you have an indication of how long it's taking?
I have to say, we don't from the surveys. I think it's been, I think I can speak from personal contact with people with long COVID. So the long COVID support group that has contact with 40,000 people, I think they have seen that some people have at least been able to return to work gradually. And I think one of the videos, Marlu, I believe, was mentioning how she had gone back to work. So if that might be a small marker that some people are seeing some improvement from those early days. But for the people that I've spoken to, it has taken the best part of a year, and I know that's not that might not sound like hope. What I would say is that I've never seen anything like this in terms of a response from the research community to try and understand what is going on, to try and understand treatments. We're seeing publications written in record time, and as soon as something is ready, it is out there. And just to the point of earlier around stratifiers and lumpers, I mean, I guess that is something at least that FOSS COVID has released a paper, and I'll put it in the chat in a second, but that at least for that, their early analysis of the first 1,000 patients in that study, we were seeing at least 4 main clusters. And hopefully that will lead us to understanding, okay, well, maybe it's some people with a certain range of symptoms will respond to certain treatments. I don't want to sort of promise more in terms of what will happen, but people are working day and night on this.
Yeah, and I think that's a great message. And Martin's one of the people who's working. So, Martin, any thoughts on trajectories of recovery or anything early on about characteristics of who gets better?
Actually, yeah, it's still early to say something about that, but I think we need to, about recovery, I think we need to ask our patients the questions if they feel they are fully recovered in comparison to before, after and before the infection, because nowadays we are always looking at just the amount of symptoms that are prevalent, but sometimes some symptoms were already prevalent before they got infection. If they had some like comorbidities like COPD or asthma, they're often suffering from dyspnea or shortness of breath. So I think we need to have like a good case definition about what is long COVID, and we are still, I think the researchers are still finding out this case definition. If we can speak, if we say someone is really recovered or not, because nowadays we are just based on symptoms. I think a good definition and good criteria are necessary to say something about the trajectory and if there is real recovery or not.
Yeah, important point. Danny?
Yeah, can I just sort of add a point and make a plea that I think we all agree that the timeline to recovery is one of the most critical questions, and it's the thing that people most desperately need to know. Is this a 1-year question or a 2-year question or a lifetime question or what? And it's the one where the researchers and clinicians really lean on all of the patient-led support groups who have been the research leaders in this, because it's very hard for clinicians to understand, to gather the data. Because if somebody just drops out and leaves, is it because they lost interest, they got better, they died? We don't know. So we really lean on the support groups for that data, which is absolutely critical to understand the kind of decay curve of the symptoms and get a feel for, does it look any better at 6 months or 12 months or 18 months?
Yeah, completely agree. And I also completely agree with the comment that it's been the patients that have led all of the driving of this research agenda, which has been fantastic. Marianne, do you want to ask any questions?
No, I don't want to really I just want to say that I've been struggling with this now since end March 2020, and I've tried a different approach, trying just to work out and get better. Then I realized that was not really working. Then I'm trying to rest. I'm not sure that works really either. So you are kind of left in between. You tried, regardless of what I try, I'm still left in the same state, kind of. Slowly I probably get better, but I don't know exactly what it is that I do, or if it's just the illness itself. And I think it is extremely frustrated.
Yeah. So, and that's a message that also came through in our earlier patient presentations. I think this frustration is clearly a big part of this, and a plea for understanding in several of the presentations today. I can see at the moment the top rated question is a question about potential reinfection. And I'm going to broaden this question a little bit to also ask you about the vaccine and whether people with long COVID should be encouraged to get the vaccine. So the question that's in the chat is, are people with long COVID more at risk of reinfection? And the counterpoint to that is if you could address the question of vaccination as well. I'm going to throw that to Danny because that's definitely got an immunology flavor.
Yeah, no, this is definitely my cup of tea and the kind of research that we and other people have done. So let me first of all talk about reinfection. So of everybody on the planet who's ever had natural infection with SARS-CoV-2, we know that maybe there's a tail end of 10% of people who've got the lowest immunity, who have the kind of normal, de novo risk of getting infected all over again. And so how does that apply to people with long COVID? So my experience of people with long COVID is that there are some who feel they may have got it because they had too little immunity, and some who feel they may have it because they had too much or hyperinflammatory immunity. And from what I've looked at so far, I'm not totally convinced that either of those are necessarily explicitly the case. So I take that to mean that somebody with long COVID has precisely the same risk as anybody else on the planet of getting reinfected. So, so it's no more or less a worry than any of the rest of us on the planet. So, make of that what you will. Obviously lots of discussion about vaccination and long COVID, and the first major controlled trial is underway at the moment. Well, a few of them, one in the UK and one in the US that I know about. And from some preprints that are out at the moment on surveys, again from the patient groups, my reading of the data so far is that of everybody with long COVID who's been vaccinated, perhaps 40 or 50% report improvement, at least in the short term, and the rest are divided between the ones who say they felt worse and the ones who felt no different. So I think that's a work in progress as far as I'm concerned.
Yeah. Does anyone else want to come in on that, on either the immunology or the vaccine side? No. So another question that's coming up a lot in the chat is about the impact of exercise. So patients are sometimes being told to exercise, but they're finding exercise absolutely exhausting, worried that feeling means that they're doing harm to themselves. I'll start with Krishna and Martin, whether that sort of concern over exercise is something that's come through in the patient surveys, and then ask Betty from a multi-organ point of view what we think's going on there.
Yeah, I mean, I think I can say it's absolutely something that we're hearing from patients, that they're constantly seeing on TV, oh, well, exercise will always make you better. And for them, it's not. And I think that's been reflected in some of the studies as well. But yeah, absolutely something we're seeing.
Martin, anything to add?
Yeah, we didn't ask it in our questionnaire itself, but we left like an open text field so they could give some answer that weren't in the list, and we saw a lot of post-exertional malaise passing by, that people did some exercise and got a relapse afterwards. So about exercise and recovery, I think some people will benefit from it, but it will depend on the patient itself. So not everyone need to do exercise. Not everyone will benefit from it, but some maybe will benefit from it. And it's not black or white. And that's a difficult thing. And long COVID is new. But we need to be cautious about that. Some people are telling us that they are experiencing some relapse. So we need to be cautious about that as a therapist. But also we do not have to exclude everyone, because maybe some will benefit from it.
Yeah, and so Betty, do we know anything at the moment about the mechanisms of that? So you made in your talk a nice distinction between the hospitalized patients and the effects of being in hospital versus the effects of COVID. And we know people who are in hospital get muscle wasting and deconditioning, and exercise is kind of our routine treatment for post-hospital rehabilitation. So do we know anything about the mechanisms of why this seems to be different for some people?
Yes, so absolutely, James. I mean, I think it really comes down to it is going to be quite a heterogeneous group of individuals, in the sense that there will be some people who will benefit, and I suspect when we look at the ICU literature and patients and data from patients who have received rehabilitation from being in hospital for a long time, it would appear that those who are admitted to hospital may actually have a stronger benefit from ongoing rehabilitation. And the reason for that are many. When you're in hospital for a long time, there's wasting of muscles. The muscles themselves that have mitochondria, which are little power cells, start getting depleted of the mitochondria. And of course, there's effects of therapies. So, for example, steroids can result in wasting of muscles and just the acute stress of illness. So what a number of studies have shown in other diseases where people have been admitted to hospital for a long time is that rehabilitation really helps restore the mitochondria, restore the muscle bulk, restore muscle health in people. And it does seem to help some people. But it's not a one-size-fits-all solution here. And we know that there are some people who just won't recover the way others do, and it really should be tailored to the individual, and more research should go into understanding why some people tolerate it and why others don't.
So we've got a couple of minutes left, so I want to address something that came through in all of the talks, which was the need for more understanding. And Betty, you I think used the perfect word, which is a bit of compassion. Why is this currently a bit misunderstood? And what can we do to provide better information and make patients feel a bit more supported? That's a difficult question for 2 minutes, but I'm gonna throw that to Krishna first.
Thanks. I mean, I think it's obviously about us being connected to people with long COVID, constantly getting that information about answers to the questions that we're asking in this panel today, and adjusting what we're doing in terms of support and research based on their input. I mean, just on the last point around post-exertional malaise, it's through hearing from people with long COVID that we've changed our advice. So I'll post something in the chat in a second for all attendees, but even our advice on breathing recognizes that for some people that's going to get worse. So there are techniques that are deliberately recognizing that. So I mean, obviously we have our website, and I post my contact details, but we always want to hear more from people with long COVID. So please don't feel like we're not listening, or that your voices aren't being heard. That we want to try and make sure that they're heard by the right people, not just researchers, but even the people funding the research.
Yeah, very important. Danny, final comment before the break.
Yeah, my little bit of wit and wisdom that I think it's just a plea really for a bit of tolerance and understanding, because we've got the perfect group on this call. We've got a lot of patients and support groups, and also a lot of professionals, sort of medical professionals. And I can understand both sides. We've got very, very desperate patients who are desperate to restart their lives and get back to normal and work out what the hell is going on and get some help. And on the other side of the table, you've got a terrified healthcare professional, perhaps a junior doctor, who's been plunged into a clinic, has no tests to give, no understanding of the disease process, and a very angry person in front of them and doesn't know what to do for them. So let's just understand each other a little bit.
I think that's an absolutely perfect description of the situation in a lot of countries at the moment. And yeah, a good message to finish, which is understanding, compassion, and trying to work together to find some solutions.